Welcome to this clinical walkthrough on a Bell's palsy case for UKMLA, brought to you by Mediate, your 24/7 practice partner.
Okay, let's dive into this. We're going to break down this classic exam scenario using a 5-stage consultation blueprint. Nailing these steps will help you master your approach for the big day, covering everything from that first hello to the final safety netting.
All right, first up, the patient encounter. We'll focus on those crucial first few moments, how to build that rapport and gather those initial vital details.
So, the scene is set. The first thing you've got to do is lock down these key details. We have a postpartum woman just 2 weeks after her delivery, and she's come in with sudden facial weakness that started just yesterday. Now that postpartum bit, that's a huge clue and known risk factor, so your clinical senses should be tingling right from the very start.
Okay, now that we've got the basics, it's time to dig deeper. We're moving into a systematic history. And look, the whole point here is to ask really targeted questions to make sure we're not missing something more serious lurking in the background.
This question, it's absolutely critical. It's one of the key things that helps you differentiate. If your patient can't raise their eyebrow on the affected side, you're immediately thinking it's a lower motor neuron lesion. That means the entire side of the face is affected, which of course is a classic textbook sign of Bell's palsy.
In this next one, this is all about immediate safety. The answer here is going to directly shape your management plan. Why? Because if that eye doesn't close all the way, that cornea is exposed and at risk of drying out and getting damaged. That makes eye protection a top priority.
So you'll want to run through these specific questions to really map out the extent of the facial nerve's involvement. It's like you're creating a detailed picture of the weakness. And trust me, examiners love to see that you're being this thorough.
Okay, we've characterized the weakness. Now the priority has to shift. We must screen for red flags. You have to be super methodical here, because the last thing you want to do is miss something truly dangerous, like a stroke.
And here's a big one you absolutely cannot forget to ask. You're hunting for Ramsay-Hunt syndrome here. Finding those little blisters around the ear? Well, that's a total game changer for your diagnosis and your entire management plan.
Think of these next questions as your central nervous system check. You're looking for any clues that point away from a simple Bell's palsy and towards something bigger going on in the brain. Getting a no to all of these? That's when your confidence in it being an isolated facial nerve palsy really starts to build.
All right, you've gathered all your information. Now it's time to put all those puzzle pieces together and deliver the diagnosis in a way that's super clear and, just as importantly, empathetic. Now this slide is so important. This is the key clinical finding that separates Bell's palsy from a stroke. Remember, in Bell's palsy, a lower motor neuron lesion, the entire side of the face is weak, forehead included. But in a stroke, an upper motor neuron lesion, the forehead is usually spared. That's a huge point. So, putting it all together, sudden onset, weakness in both the upper and lower face on one side with no other scary neurological signs, that leads us straight to our working diagnosis, Bell's palsy. And remember to call it idiopathic, a fancy way of saying we don't know the exact trigger.
So how do you explain this? Keep it simple. But honestly, the single most powerful thing you can say, the thing they are desperate to hear, is this: it is not a stroke. That reassurance is absolutely everything.
And this is the perfect time to actually practice these skills. You can practice this exact case right now on mymedate.com, get objective feedback, and even audio playback. It's a great way to lock it all in. Okay, so now let's talk about the management plan.
All right, let's get into the management plan. Having a clear, structured, 6-step approach is what's going to show the examiner that you're safe, thorough, and you know exactly what you're doing. And here they are. You've got to cover all your bases. We're talking immediate medical treatment with steroids, that urgent eye care, practical advice for at home, and not forgetting mental health support and follow-up. It really is the whole package. Let's talk about this 72-hour window. It's so critical. You have to get those corticosteroids, like prednisolone, started within 72 hours of the symptoms starting. That's your best shot at knocking down that nerve inflammation and giving the patient the best chance for a full recovery.
I'm gonna say it again. Protecting that eye is a clinical emergency. You have to make a same-day referral to eye casualty. No excuses. And while they wait, give them concrete advice. Wear sunglasses, use lubricating ointment, even tape the eyelids shut. It's all about preventing permanent damage.
Okay, we are on the home stretch. To finish the consultation strong, you need 2 things: a crystal clear summary and some really solid safety netting advice.
So you just run through the key points again. The diagnosis is Bell's palsy. We're starting steroids. You need to go to eye casualty today. This makes sure they've actually understood everything. A great pro tip, if you have time, ask them to repeat the plan back to you in their own words.
And never, ever let the patient leave without clear safety netting. Tell them exactly what to look out for. If the weakness gets worse, or you start getting weak in your arms, or see a rash, you need to come back right away. This is so important for their safety. Okay, let's think about this for a second. What's the single most critical action for this patient's immediate safety? Now, steroids are vital for recovery for sure, but the number one thing to prevent permanent harm, it's that urgent referral to eye casualty. Nailing that point is how you ace this station.
You can practice this exact case now on mymediate.com.